welcome to the American Bifurcation Club monthly webinar, or the Bifurcation Hour. This has been pretty well attended over the past few months, and I think people enjoy seeing these cases. So today we have two experts who present a case. The case format will be between 15 to 20 minutes of case presentation discussions. So the first presenter will be Dr. Richard Shlofmitz from St. Francis in New York, and Dr. Matt Price will be the discussant. This will be followed by our guest from the UK, Dr. Hassoon, who will present the case, and Dr. Price and Shlofmitz will discuss the case, and then finally Matt Price will present his case, and Dr. Shlofmitz will be the discussant. So Richard, without much ado, let's get started with your case presentation, and everyone else can mute themselves.
What you got, Richard?
All right, so I'm going to be talking about precision angioplasty using OCT guidance with multi-vessel coronary disease. And it's no surprise that I'm going to be talking about OCT with this, but under that, you see it says that the technology we use is only as accurate as the operator, me being the operator. And I possibly have done as many OCTs as anyone in the world, and I think it's amazing technology, but it's easy to make mistakes. So this is an interesting case. It's a 45-year-old male with severe three-vessel disease. He was referred to me from another institution where they did a couple of angiograms, but not very investigative. It was poor surgical targets. They had recommended surgery, and he came over to my hospital. So he had multi-vessel disease, and when I did the angiograms, I start with the right coronary artery, and you see he had mid disease and PDA disease, and this was one of his best arteries. So all this is image guided, and I stented the mid right and the PDA, and we got a very nice result. So this is his right, no problems, everything's great there. When I got to the left system, it looked a little different than their angiogram. And I went in with a 7 French guiding catheter because I thought I might have to do a bifurcation. The left main looked good on their pictures, and there was no indication it was left main disease. You see that there's mid-circumflex disease and distal circumflex disease, and the LAD, not in this view, you can't tell, has disease as well. So, you know, the proximal part of the circ looked like it was preserved. And I had damping with the catheter, so I was concerned I had left main disease. So what I was hoping to do was treat the circumflex and hope that the ostium of the circumflex was okay, and then I was going to assess the left main and the LAD. So that's what we did. So I then imaged, and the pre-LAD disease with left main and proximal LAD had non-obstructive disease. So here you have an RAO projection here, and you see that there is left main disease, and the mid-LAD angiographically looked like it had disease. The proximal LAD didn't look that bad angiographically. You can see that he's not a great surgical candidate. So I did an OCT pre-LAD in the, and this is starting from the pre-LAD, not the mid, the proximal LAD and the left main. And what you can see on the OCT here is that the disease goes into the left main. His areas in the left main are significant, and there's lipidic plaque. So I immediately knew I had a problem here. And let's see if I could drink. It'll play here. I can't stop it on this. But you see that this is the proximal LAD, and we're going to be coming up real critical lesion. The MLA is 237 in the left main. We went past the origin of the left main with the LAD and circ bifurcation. So I have a problem here is that I have proximal LAD disease, I have left main disease, and
Richard,
yeah.
Richard, I'm going to stop you there. I'll keep you on time, but real quick, let's just talk real quick about OCT left main disease. Mm-hmm. So, for example, you had the OCT open already for the right coronary artery, but let's say this was the first vessel you were going to do. Would you have leaned towards intravascular ultrasound rather than OCT because of the extent of left main disease? Or if it's just the distal left main bifurcation, you're happy with OCT? Walk me through your thoughts.
Okay, so there's no question in my mind, when I'm dealing with the left main, I want an OCT and not IVUS. And a lot of guys I work with here use IVUS for the left main. But in terms of co-registration, to be able to nail your ostium, your LAD, and circumflex, to make sure that you have no dissection, to make sure that you're one-to-one with the precise precision, size, and length, I always go to OCT. Now, I may at the end use an IVUS just to see the ostium of the left main to make sure I did it perfectly. And I'll use both technologies. But to get pristine results, I always use OCT.
Okay.
Now, I jumped ahead here because I'm going to get to the interesting parts here. So here, I already went and I OCT'd the circumflex, and I see that the mid circumflex to the distal circumflex, we have a great result. And the proximal circumflex by the ostium is not significantly obstructed. The areas are greater than 4-5. And I ended up stenting the left main and the LAD. I had to go from the mid LAD, as you could see, to the proximal LAD to the ostium of the left main. And I did not have to cross over into the circumflex, and I OCT'd both the LAD and circumflex to confirm that. So now I have left main, proximal LAD, mid LAD stents, mid distal circ, and right. This is 2.5 hours. You know how long it usually takes me to do a case, Matt. And this is 2.5 hours. I have 15 more cases.
Office is calling, Richard.
I'm sorry?
Your office is calling you.
Everybody's calling me, right? I'm 2.5 hours into it, but I'm going to do my final OCT run. So this is my final OCT run. And if you look at the 3-dimensional and the 2-dimensional there, I have pretty good result there. The vessel's open, you'll see. And I think I'm fine. And I'm going to go back 4 hours later. The guy's having chest pain with ST elevations, and I bring him back emergently to the lab. And I'm thinking, how could this be? I did this. I opened everything. I imaged everything. If you image, you shouldn't have any problems. And 4 hours later, I do this angiogram, and look at the ostium of the left main. Do you see the stent?
Yeah.
Right. So I have a problem with the stent. The vessel's open, but I have a problem. So now I pulled out your IVUS. And you see,
that's not my IVUS. That's a the megahertz. It's a low megahertz IVUS, but we will call it IVUS if you'd like to.
Okay, so but it's IVUS enough that you can see what's going on here. At the ostium of the left main, you see that there's a hematoma, and I deform my stent with thrombus.
Do you go back to those? Are you going to show the OCT again?
Of course I am. That's what I screwed up. Okay, so this is an interesting case because I didn't look at the OCT close enough, and OCT can absolutely tell you when you get left main stent deformation, which is well described.
What's really interesting here, I mean, beautiful. I mean, it's a beautiful shot on the IVUS. Is at 3 o'clock, from 12 o'clock to 4 o'clock. It appears there are 2 layers of stents there, doesn't it?
But there's only one.
Right. So that's bad.
Not good.
No.
Not good. So I'll show you what I did wrong here. So anyway, I go back in, and I could have potentially just ballooned it, but I went back in and put a stent in.
Yeah.
And then I IVUS'd it again, and now I have a perfect result finally. So here's where the problem is. Here's the OCT. And you see on the right, this was present, and I'll go back to it, but I missed it. As you pointed out, Matt, there are 2 layers of stents there. Now, you might look at this superficially, and if you had an overlap of 2 stents, you would say it's just 2 stents that are overlap, you just have to balloon it. But what this actually is stent deformation. And it comes from the guiding catheter in the left main with the stents we use. And this was described in JACC, the frequency and impact of acute stent formation after angioplasty of the left main in the Excel trial. And it happens 6.6% of the time, and has very adverse clinical outcomes, as you could imagine. So this is something that I wanted to present because we're talking about a lot of left main stents in this club, and we're talking about bifurcations, and I'm going to play it again here now. But this is something you all need to be aware of, and I missed it. So fortunately for the patient, he was still in the hospital, and I was able to bring it back. It's going to be coming up just about there.
Right there. And what happens is it gets hidden in the blood swirl, right?
Exactly. So I missed it. It came through in the blood swirl. I looked at the whole thing. It was looking fine, and I blew it.
Yeah. How'd the patient do? Okay.
He's been great. This was a couple of weeks ago. He's doing fine. He has no angina, and he's done fine since then. So I just thought this was an interesting case.
It's very nice. I mean, I think that it speaks to many things. First off, that even the best of, I mean, Newman's done more intravascular imaging than you have. And no one's perfect. Number two is it speaks to how careful we have to be when we're putting in ostial left main stents because of the guide. And what can happen is you can have distal apposition and proximal malapposition. And if your guide pushes on one edge of that stent, it will tip it over and deform it. Right? So doing a pot carefully. But often when you're trying to get your pop balloon down, it may not go very well. So you deep seat your guide and then you have a problem with deformation. And then it goes to the question. I mean, I didn't know that. I guess it was the question I had forethought was this IVUS versus OCT for proximal left main. So I mean, and this is not critical of you at all. I have the same issues because I'll be doing OCT and then I stumble upon having to do an ostial left main. It happens. And do I spend the extra $600, $700 to break out an IVUS to really check that ostial left main? And I often will not. And maybe I should be. So
well, the thing is, you saw it on the OCT. It's just with the blood swirl, it was 2 frames and it was on the blood swirl, so I just missed it. But it's something that I should have seen. And, you know, the alternative, obviously, if you IVUSed, you would have seen that also at the ostium. But it's something that, if it happens, has very serious outcomes, obviously.
Right. Can I ask? We're non-denominational. What kind of stent was that you used?
It was a Abbott stent,
which supports the very thing I'm going to say is that it happens to all of the stents, because the Zion stent is thought to be the most rigid of the stents that it's going to happen the least with. But I've seen it with all the stent manufacturers. So once again, I think longitudinal stent distortion can happen to any stent, particularly in very large vessels. Because you went from LAD to left main, right?
Yes.
So you probably sized it to the LAD.
And then post-dilated.
Right. So that you had this fixed, it was fixed distally in that LAD. So and that happens with bifurcations all the time when you have a mismatch between side branch and main vessel. So that's a great example. Milad, any thoughts out there in the UK? We'll bring you into the conversation. Unmute yourself, though. We still can't hear you.
You just unmute, Milad.
When we attempt the left main stem, my bosses always told me just to pull the balloon back and make sure there's a good distance between your potting balloon and the edge of the catheter, and go as far as you can, flare it up quite well. But even doing that, I mean, obviously you can't avoid such complications.
Terrific. Well, look, that's Richard. We'll move on to Milad's talk. I think you and I are going to be the discussants for Milad, who's coming from Wales. It's late. They left the hospital office doors open for you, I guess. It's like
a couple of things. Imagine, Richard, a couple of things. Don't you think there's some clue on the angiogram? You could see that, sort of a napkin-like effect right the ostium. And
as soon as they did the angiogram, when I brought him back, I knew I was in trouble. Yeah, definitely. That's why I showed the fluoro of it first, because you see it pinch. You're absolutely right.
And the other question is something from the audience asking, would you have done physiology on the circumflex side branch or not?
The mid circumflex side branch?
Yeah. Yeah.
It was, I don't know, I thought it was something like when we talk about provisional stenting and ballooning, it was a small vessel. And I think this guy had severe multi-vessel disease. I got his best vessels, the best results I could get. So I didn't go after that small OM.
I think you're talking about the circumflex proper. Non-dominant circ, you stented across it. There's maybe a 50% osteal lesion. You made the call to leave it alone. Clearly, he had bigger fish to fry, it seemed, in the left main. So,
yeah. And by the way, he was hypotensive with that guide in there. He kept dropping his pressure to 60, so I had to move quickly.
But the question is, should you do physio? I mean, I don't routinely do. In fact, I extremely rarely do physiology on side branches. We could talk about that more maybe in my talk.
Jeremiah does it all the time. But what I always find interesting, guys, is that when I speak to Alan Jeremiah, one of my associates, who's a big physiologist, and when we do physiology on the RCA and the circumflex, and it's always negative, he goes, "Well, it's always negative there. It's not enough myocardium." I go, "Well, then why the hell are we doing it?" But you know, God only knows.
All right, Milad, you can start sharing with us. And welcome once again, all the way from Swansea.
Swansea. All right.
See my screen yet? No.
We can see you still. We don't have your slides just yet. Okay, you give it a moment. There we go. We now see your slides.
Excellent. Well, thank you very much again for having me here. My name is Milad Hassoon from Marsden Cardiac Center. I'm presenting this case of decay crush of an aneurysmal bifurcation, also on behalf of my colleague and consultant, Dr. Hayman. We have an 81-year-old gentleman who presented at the end of last year with NSTEMI, and his initial admission was complicated by DT, which is an ischemic-driven degenerative VF arrest. He was resuscitated and survived it, and he was stable at the time of arrival to our lab in a few hours. He had a past medical history of hypercholesterolemia, mild COPD, poorly controlled hypertension, and he has problems with his joints and back. It keeps him uncomfortable and flat. And he was also an ex-smoker. From the cardiac point of view, his ECG showed clear inferior ST changes, and his echocardiogram showed only mild degree of LV systolic dysfunction with no valve abnormality. His coronary angiogram was done via the right radial artery approach, and it has shown chronic total occlusion of the right coronary artery and the distal part of the RCA territory receiving collateral from the left system. In the middle, you can see the severe, the left system. There is no clear left main, really. There is an adjacent origin of both the LAD and CIRC. And the CIRC itself has got severe disease proximally and more diffuse severe disease distally, which is likely the culprit in this case. On your far right side, you can see the LAD is also has got nasty disease proximally and very complex bifurcational aneurysmal disease involving the second diagonal, which seems to be sizable. So to sum up, it's a severe three-vessel disease, and we discussed with the patient the option of going to surgery. The patient was quite clear that he was not keen on having surgery, and he would like to be quickly to. So we proceeded to PCI of his left CIRC, which we believe that's a culprit lesion, and it was a straightforward PCI. We deployed a single 3.5 by 33 drug-eluting stent, securing the flow to the distal vessel. We didn't attempt the left system on the same session. It was the end of the list of that day. We wanted to have a kind of a fresh start next day, especially that we already have a stable patient hemodynamically, and we have dealt with the culprit lesion. The thing that I would like to highlight about this lesion of interest for this presentation, that this is a Medina 111, obviously, with a bifurcational aneurysmal lesion affecting a side branch, which we think it is large enough to have a two-stent strategy. That's why we plan for the next step to go for a two-stent strategy if we are managed to wire the side branch, which is the expected main challenge. Now, as expected, passing the wire to the main vessel was not a problem, really. Passing the wire to the side branch was a big problem. The wire kept coiling inside this chamber, this aneurysmal path. And despite the fact we tried different wires, tried different shape of the wires, we were not achieving anything. It is not just like passing a wire in a teapot and trying to find at that point, of course, as interventionists, we try to think of a different ways of dealing with that. Because dual lumen catheter and angle tip microcatheter in all shades. However, in our case, the patient started to develop chest pain and he started to be restless on the table. We dealt with that, but when this happens, it's just the patient when restless, all the situation is different. That is a sign for the operator to crack on and make some progress. And it's not the time to try these different gadgets, which are probably have no guaranteed outcome. So we resorted to the old trick in the book. We just put the wire in the first diagonal and we started ballooning across the bifurcation to secure the flow to the main vessel. And also we used compliant, non-compliant, and scoring balloons. We prepared the lesion of the proximal to mid-LAD quite well. And then we took a picture, and as you can see, the flow to the distal vessel is secured. The side branch is more obvious now. It's a sizable branch. And we cannot see, compared to the original angiogram, much of the aneurysm there. We have created multiple dissections, of course, and that's expected proximally and at the site of the bifurcation. So on attempting the wire actually went quite easily to the side branch, and we managed to secure wiring both vessels. Now, we planned decay crush, but if you think about the geometry and the sizes of both distal vessels, the diagonal and the distal LAD, someone might say, why not a kilot? The angle is favorable and the whole geometry is favorable. However, we did not want to move that wire that we already placed there. We have created so many dissections, problem micro dissections, that we don't want to go again with another wire or remove that wire again. So that's an important feature to remember about the technique that we attempted. And therefore, we proceeded to do a decay crush. We placed a 2.5 by 28 stent in the LAD with the balloon part in the main vessel.
I'm going to interrupt you there, Milad, for some discussion. Okay, so great case. So you basically did you modified the plaque to allow you to wire that large side branch. My question for you, if you're going to use a bifurcation stent technique, is how you are going to size the main vessel stent, given this aneurysmal portion. So did you do any intravascular imaging? If you do, if you're truly going to crush this, you're going to need a massive stent in the proximal. You're going to have the side, your stent is almost going to have to fill the entire aneurysmal space.
Yeah, I mean, in this particular case, because the patient was uncomfortable, we wanted to do the stenting as quick as possible. The ideal way is to do a run of fibers first for sizing before we proceed to deploy any stent. But we rely on the angiographic assessment of size, and we proceeded subsequently. I agree with you, the right way of doing things is to fibers first. But when you have the patients uncomfortable, keep moving, we are under the pressure of time that to achieve stenting, we relied on our visual assessment for sizing in this case. And as you know, our modern stents are quite flexible. So the IVUS, as I will show later on, was on the table and going to be.
Okay, you can continue. Go for it.
We relied on our visual assessment.
So I'm sorry, just so I could see it, so I'm following you. Bottom left picture, you have a 2.5/28 stent in the diagonal, and you have a balloon in the LAD protecting the LAD. Is that correct?
That balloon is a part of the technique, so it's parked in the LAD to prepare for crushing.
Right. But your stent is just in the diagonal. The stent's not across the diagonal into the LAD.
And
Yeah.
how big of a balloon do you have in the LAD right now?
We have a balloon in the LAD parked there. in
Right.
anticipation for crushing.
Yes. What is the diameter of that balloon?
Oh, that was a 2.5 by 15 balloon.
So I
And
guess
the-
my question, I'm sure you got a terrific result, but we're here to grill you and ask you questions. How is a 2.5 balloon possibly going to crush sufficiently in an aneurysmal segment, which is like
Yeah,
a
but
4?
if you look at the distal main vessel, and this is a compliant balloon, and we took it to a quite high pressure.
Let's see what happens.
Yeah, I'll show you what happens. Yeah. So before that, I just would like to remind my audience that's important when you deploy the side branch stent, is to pull the balloon back and go up again to optimize the stent before crushing it. And this is why the picture I put it down there. Then we pulled back the balloon and the wire from the side branch, and we crushed the stent. The next step was to wire the side branch, and that went without any problem. And then we performed the first kissing balloon inflation, followed by, I'm sorry, I don't have a moving picture for that, but then we chose a long stent to the LAD, 45 stent. And we deployed it from all the way from the ostium to the distal portion, followed by potting of that proximal LAD stent, and then we rewired into the side branch stent, and the rewiring was absolutely fine with no problem. Then we performed the second kissing balloon inflation and potting both above the level of the bifurcation and at the proximal LAD. Our final results, and of course, we performed IVUS at this stage. And as you can see on your right upper corner, the IVUS run at the area of interest. The stent of the proximal LAD well expanded. The stents at the bifurcation and the distal LAD are good. We tucked a small stent here from just at the end of the main LAD into the distal LAD to deal with a moderate residual disease. And we post-dilated vigorously. The IVUS run, as you can see, and I just took the clip for the bifurcation, so good stent expansion and a position at the bifurcation side. We have seen this patient again in our clinic 2 months after the procedure, and he's doing absolutely fine, free of angina, back to his normal activity, and therefore we did not plan any further intervention, in the sense there's no need for attempting any CPO for the right coronary artery. Before moving to the learning point, did I answer any of your queries yet?
Yeah, could you just go back a couple of slides where you have your stent in your diagonal and you have your protecting balloon, which, no, before this.
Yeah.
Go back. Oh, right there. So I don't see I just see the balloons there. That stent in the diagonal is extending into the LAD there?
Yes, correct.
Oh, it looked like it was at the origin of the diagonal to me from where the balloons.
Yeah. This is important to gauge how far are you into the main vessel. So we use that as a marker to know how much we're protruding back from the LAD to the main vessel. And this is the rationale of having this parking of the initial parking of the balloon. And the
I recognize that the patient was unstable, so you had to move quickly. What I typically do is, using co-registration, I mark it exactly with OCT, so I know exactly to the millimeter where I am. But because on this film, it's hard to tell from here. At least to me, it looks like an LAD diagonal bifurcation with the way the wires are there. But you're in.
I think a steeper. I'm sure it looks great. Potentially a steeper eleocranial may have highlighted exactly where the takeoff of that diagonal was. So you could test with contrast and make sure you just have a little bit in the main vessel itself.
Correct.
I think it's a great result. Very nice.
Great, thank you. So I think for me, I have reflected on this case many times, and I just have two learning points really that I would like to share with our audience. I think it's important to remember that the breakthrough point in this case was the ability to cross to the side branch. And we are dealing here with an aneurysmal bifurcation. And we know that histologically that the wall of this aneurysm part retains the three layers, but it's just a matter of a dilated chamber. So probably we took that pragmatic decision based on the things that you usually do when you transcross to the side branch, just balloon across it, and we have 50% chance. But actually, I think that the chances in dealing with aneurysmal bifurcation of stretching that thin wall back and rearrange the geometry in a more favorable way probably work much more in our favor in case of aneurysmal bifurcation, because the chance of any plug shift from that aneurysmal part to block the access to the side branch will be less. However, that's just probably what happened with us. Not all the coronary aneurysms are of the same size and shape. They are saccular wide angle, saccular narrow angle, fusiform, and sometimes the ectasia. But it just shows how important to understand when you have an aneurysm at a bifurcation, you know where the geometry and how they are, how this geometry is going to respond to angioplasty. The second learning point, I think it's important. We always, when we choose our technique and to deal with two-stent strategy, we based on algorithms, based on the angle, based on the lesion distribution, the size of the stent branch, etc., which are all absolutely fine and work. But in this particular case, our priority also is to preserve the position and access of the wire to the distal branch. So that can, as you can see here, we could, if anything, we cannot risk the patency and access to the distal vessel because it supplies such a big area of myocardium in the distal LAD and also collateral vascular. And this is where decay crush feature of keeping the wire in the main vessel always there, I guess suits more than Kilot, even if the bifurcation anatomy is appealing for Kilot.
So Milad, we have a couple of questions, which I will ask Richard, and maybe Tanvir can get on as well. Okay, so first is, and I think you did address this, Milad, a little bit, but why not use a microcatheter to wire that side branch of the aneurysmal segment rather than using a angioplasty balloon to modify the plaque? I gather the patient was beginning to become unstable, so he just wanted to address the main lesion, I suppose, at first. And, but certainly you could use an angled microcatheter. Would be nice. So was there any thought of using an angled microcatheter to begin with to wire?
Yeah, of course, they were ready on table, and we thought about the difficulty of wiring the side branch, and we expected that difficulty. Just to highlight that probably even with angled microcatheter, your access within this chamber of aneurysm is not really guaranteed because everything was coiling the geometry of the bifurcation. And I'm just highlighting that sometimes as an operator, you'll be forced to take some pragmatic decisions and get the intervention progress. And even when you thought that there is a tool in your hand, it needs to be used.
Yeah, certainly, even with outside of aneurysmal segments, simply bifurcations with very challenging takeoffs that cannot be wired standard ways. Sometimes taking the risk of ballooning across the bifurcation to modify the plaque and the channels can be favorable for the operator. Another question, maybe Tanvir, you can answer this, would be any comments on how much stent length to crush within the main vessel? So when you're doing a DK crush, are you crushing 15 millimeters of stent, 0.1 millimeters of stent? How much stent are you crushing? Or I should say, how much stent do you think you're crushing when you do it?
I think, you need to have enough length to take at least 8 millimeters balloon in length. and you really need to size it to the proximal segment and go right up to the carina, and really size 1-to-1 on the proximal segment to crush the struts right up to the carina. So it has to be large balloon to the proximal segment, at least 8 millimeter length. So at least you have to have that much stent segment above the carina to be able to do that. But it has
So
to be.
I guess the question is, if you're going to, like when Milad and his colleagues are putting in the stent to the diagonal, is how far back into the LED do you put that diagonal?
Oh, for the diagonal, at least 1 millimeter or 2 into the LED, at least a minimum. That's the current teaching, at least a millimeter.
You're right. So you don't want to do a swing and miss, because there's nothing worse than that. On the other hand, the classic crush was a lot of stent. And some would argue that when we did classic crush, we are always doing the mini crush. We never really did a ton of stent, but you want enough so that in your mind's eye, if you deploy that side branch stent, that the proximal segment would be completely within the main vessel itself, whatever that, how many millimeters that might be based on the angulation of the side branch. Would that be about right, Tanvir?
Yeah, I think so. And the other thing is when you have a wire or balloon as a marker, the central lumen of the balloon, when you have the tip of the stent balloon, when it touches that other close to the other marker, it's probably 1 or 2 millimeters into the vessel. And that's a reasonable, sort of a indicator that you're well within the vessel. If your tip marker with a stent from the side branch sort of touches the middle lumen where the wire goes through, those two sort of give you a reasonable idea that you have enough stent within the lumen of the vessel.
Certainly using OCT and co-registration, as Richard alluded to earlier, you can really, because sometimes you can't tell exactly where the carina is because of the angles on fluoro. But OCT, you'll know exactly where, whatever angle you want to be in or are going to be in, where exactly the proximate edge of the stent must land. Isn't that Richard? Isn't that right, Richard?
How many times you have like parallel overlap and you think you could do it by a wire, and when you OCT it's totally different.
Yep.
And until you become confident to listen to your imaging, and if you believe in angiography and you go by your angiogram and not imaging, you're going to get burnt because you'll be off by a couple of millimeters. The OCT tells you to the millimeter exactly where you need to be.
All right, so Tanvir, I'm gonna we have 20 more minutes.
Yes, yeah, sure. It's your turn.
A round of applause for Milad.
Good job.
Thank you.
Thank you.
Maybe it's Swansea again in the Premier League coming up. We'll see. Okay. All right.
Matt,
Let me share my screen. Wait, let me go to this again. How come it's share screen? Continue. Desktop. All right, can you see me?
yes.
All right. The title of my presentation is The Bifurcation That Keeps on Giving. All right, so this is an 81-year-old male with Canadian Cardiovascular Society Class 3 angina. This angiogram is done by one of my colleagues, one of my general invasive cardiology colleagues. It's like a Tuesday at 5 o'clock, so the last case of the day. We're right radial access. We'll make this sort of some back and forth, okay, Richard? You with me? So, all right. So here's your angiogram. I get called into the lab. Hey, Matt, will you fix this for me? So we'll just offhand, you can see there's an ostial LED lesion, right? There may be something in the proximal circ, or I guess that's the mid circ, if there's such a thing, after the first OM there. There is maybe a question of some mid LED disease.
It looks pretty bad after the diagonal, no?
Yeah, it does. All right. So, but I was looking at that LED. So my thought was, okay, 6 fresh guide. Why are both LED and circ? IVUS because by default it's OCT, but here because we're so proximal, I was going to use an IVUS because I'm worried about it's a short left main.
I was going to say it almost looks like separate osteo.
Exactly. Quick stent to the mid LED, stent the left main into the LED. I'm home for dinner. Here's the plan. All right.
Nothing with the circ. You wouldn't do the circ first?
I'm going to IVUS it and see what it's all about. You can have to fart too, I suppose. I'm suspicious about the circ. But let's get more information. All right. So IVUS the left circumflex first. I had to use my iPhone to get these images, so I apologize for that. So there's the lesion in question. The distal reference area is 11 millimeters squared. The mid-circ lesion MLA is 3.14 millimeters squared. And the osteo and the circumflex, this is important when we talk about stenting from the left main to the LAD, right? What is the state of affairs of the osteal circ? Here comes the osteal circ, or that's, excuse me, that's the left main there. Very mild stuff going on. So although I didn't FFR, and I always say physiology to decide whether to stent and imaging to decide how to stent, in this situation here, it's a huge vessel, small MLA. I'm going to be stenting from the left main to left circumflex. So my plan is just to fix the circ. I'm trying to show you here the ostium of the circumflex. I mean, there's some plaquing there, but it's huge, right? I mean, 4 millimeters in one direction. All right, so hopefully, Alan Jeremiah, who might be watching, isn't mad at me for just deciding to do stuff. So to not do an FFR. So here's the IVUS of the LAD. I pre-dilated first. There's 2 runs here. So this is the mid LAD. So first of all, what do you see about, we'll do a little imaging here. I'm going to rewind here. Anything special about this where I start, where it's quote unquote normal? Any thoughts on that, Richard?
I need orange.
Leading the witness here. Yeah, right. So this is a bridge here. Do you see that? So the moving, there's negative remodeling, thickened intima, and a bit of a winking of the vessel. So that's, and then just at the proximal edge of the bridge is atherosclerosis, is a plaque, which is classic. So right when you enter a bridge, you will see atherosclerosis having to do with shear stress and what have you. So we're pulling back here, and there's that mid LAD lesion. You said looked pretty bad. I agree. There's some eccentric calcification, right? And as I pull back here, this is again the mid LAD here. And this is the ostium of the circumflex. Excuse me, ostium of the LAD. I apologize. Ostium of the LAD. I'm going to show you that a little more carefully. Going back here. This is the ostium of the LAD right here. Any thoughts on the type of plaque this is? Oh, there's
It looks like you have calcified plaque there, right?
Yep. And here's the left main itself. So you see the left main, there's calcium here. I'll go back. So again, here is the ostium of the LAD. This is
a little nodule there.
Yeah, maybe here.
Yeah.
Yeah, although there's calcium here and here as well, right? So maybe nodular calcification versus the nodule itself, or a heterogeneous calcification. And I don't know why am I showing the circumflex again? I'm not sure. There's that lesion in the circumflex. You see very nicely there. Okay. I wanted to show the ostium of the circumflex. Sorry, here. Once again. That's again the ostium of the circumflex. I think no problem with doing a provisional stent from left main to circ. This is the Bifurcation Club. We can talk about our plans here. So let's see. All right.
Which IVUS is this, by the way, Matt?
That's the Boston Scientific IVUS, rotational IVUS, 60 megahertz. That's the new 60 megahertz Boston. All right, so I first addressed the circ using IVUS sizing. That was a 3.5 vessel. I put in a 3.5 by 26 drug-eluting stent. And I'd already pre-dilated it a little bit to get my IVUS down. So now I pre-dilate the ostium of the LAD. My plan again is left main to LAD. So I'm addressing the circ first because I'm going to be closing the door, so to speak, on the circumflex. So I want to address distal first. Good plan, you think? By the way, we didn't really talk about how you would address the left main bifurcation.
Yeah, that's what I was referring for when you do the circ. To me, you take care of the circ because you're not going to get back in there.
Right. So that's what I did, right? So you agree with a single stent left main LAD?
Yeah.
All right, good. So here's
why do you dilate the ostial circ when there's not much plaque there?
I didn't. It's hard to see, but the ostial circ is way back here. I use IVUS to document exactly where I had to stent from where to where. So I landed in normal tissue. Don't worry. I'll go back just to prove myself. Okay. So you can see that the circ goes right to about, I want to stent right back to that, just past that little OM there. Make sense? Tamir? Yep. All right.
Yes.
All right. So here's my 325 balloon at 20 atmospheres. And there's a waist right there, right at that calcification. It's hard to appreciate on this, but there's certainly a waist. Any thoughts what to do next?
Was it because
Half inch on a rota? Huh?
was there a nodule there? Is that why there's a waist?
I thought it was actually eccentric. I didn't think it was just a nodule. I thought it was almost, I mean, if you go back, I thought it was more than 180 degrees of calcium.
I would go with a shock wave.
That's why I like you, Richard. That's why we work so well together, okay? So I took a 3.5 coronary IVL. I should say this case, I just did this like, I had some other cases all set for this. And I did this case last week. And so this is perfect for the ABC. Here we go. All right, so this is now approved in United States. Milad's been using coronary IVL for the last year or so. We haven't, so this is hot off the presses. 3.5 IVL.
Who paid for it, Matt?
Say that again?
Did Paul pay for it?
I'm the director of the cath lab, so I guess I have to pay for it now. He's head of everything. I'm just the director of the cath lab. So then I just had to address the mid LED. Remember, there's that mid LED Richard commented on. I had to stent right to the bridge. I don't want to stent into the bridge. By IVUS was about a 275. So I take a 275/30 right to the mid LED.
So an important point, Matt, like on OCT, you see bridges a lot clearer. I mean, and the way you see a bridge on OCT is you see perfectly EEL with a 1.5 lumen, right? But the EEL is perfect. So
negative remodeling. I mean, yeah.
Right. So you're sure that there's a lesion there, but you see a perfect vessel without plaque. And as you well pointed out, very at the origin of it is where you always see a tight lesion. So when you stent, you just stent right across that tight lesion and you size it to what? Because you don't really know the true size of the vessel.
Right. I conservatively and carefully.
It's tough.
Is that a vague enough answer for you? Oh, that's probably why I took a 275 rather than a 3.0 here. And I post out there with the 3.0. All right. I'm all happy as clams. We're moving along. Uh-oh. Patient is sort of, begins to get a little bit squirmy on the table. I look up and there's deep ST depressions. And guess what? That diagonal, we didn't even talk about that. I didn't even notice it. I'm gonna go back. There's a diagonal there. I should have shown that first. But there is a diagonal right here. Do you see that? So in retrospect, do you think I should have wired that diagonal?
Matt, can you tell from an IVUS run, and I'm not expert in IVUS like you are, when I OCT and I have side branches, I make decisions about how worried I am about the side branches. You really can see very crisply the origin of the side branch. Can you tell that on IVUS there?
No, I don't think so. And also, but I think what's really nice about OCT is there's something we call the eyebrow side, right? So you can actually see the carina, and you have some bifurcations where the carina of the side branch actually extends into or overlaps within the main vessel itself. And so when you put a stent across that kind of side branch, you will have carinal shift. You have to have carinal shift. And that's definitely an at-risk side branch. I didn't do OCT here. Maybe I should have, and that would have alerted me more for the potential for carinal shift.
You're using a 6 French system, right, Matt?
Yeah, 6 French.
So putting a third wire really having space consuming, I guess, into that.
Yeah, but I have wires on the LED insert, like you mentioned. I was able to get a wire in there. I just took a 2.0 balloon. This is always a classic sign of a patient in chest pain, right? The hand is now creeping up into the fluoro. But we have flow now, right?
Wire, that's all.
Say that again?
He's just directing you to where to wire.
Exactly right.
You wired to the stent struts, right? Dilated that.
Yes, I did. So I prolapse the wire. So I make sure that I'm actually in the true lumen within the stent, and I pull back and preferably get, if you can, from the distal strut into the side branch. And this is probably just a run through my standard workhorse wire. My general, and there's different categories of wires. I don't mean to be brand oriented. My run through, it usually works most of the time. Sometimes I can use a run through HyperCoat if you need it a little more slippery, but it's a bit soft. So if that doesn't work, I would go to a Pilot 50 or a similar type of wire.
And your 2.0 balloon went across nicely?
It went very easily.
You know, when you have problems with an unfavorable angle, or you're just having a tough time getting a balloon, what I find and I don't know why, a 125 15 millimeter Medtronic balloon, I've never had it not cross. I don't know what it's just different. You might try a 125 Medtronic. It's interesting.
125 Medtronic, you got it, especially when I'm doing those DK crushes. That's when I'm going to need that. Okay, so all right, so we got that over with. Fine. Okay, we have this left main we got to take care of. I almost forgot about that by this point. So I take a 3.5 by 18 DS from left main to LAD. Sad face emoji, as I say after I do the angiogram now, okay? Patient has profound ST depressions, chest pain, and this is what I see.
Circumflex.
Yeah, right. Among other things, I also have to post-dilate the ostium, right? Of the LAD. Oh, by the way, this is your diagonal now. All right, so you have your circumflex is not happy. You have to post-dilate the ostium to LAD. You now have TIMI 1 plus flow in the diagonal. Patient has ST depressions and chest pain. All right, so what do you do now? Thoughts?
No dinner tonight. Okay, so
I see Raj is on the line here. So well, now I'm this diagonal is forcing my hand. I'm thinking the diagonal is probably the main culprit here because there's TIMI 3 flow in the circumflex. That'll have to be addressed. I think I have to go back, and the diagonal needs more attention. I need to put a stent in there. Tanvir, what would your stent approach for here now?
I think, this will be a T with minimal protrusion now. Now, since you already have struts sitting there, so you'd have to take a 2.0, 2-5 stent through the struts. I
suppose you could do a reverse culotte if you wanted to, right?
That would make it a little more complicated. I mean, there'd be more steps, I think. But I think if you, in this case, you have to salvage it quickly with the circumflex being compromised. I'll put a 2.0, 2-5 stent through in a T with minimal protrusion. Bring the stent back a little bit to the LAD and do a simultaneous kissing. Yeah, dab the diagonal. That's what I'll do. T with minimal protrusion.
Okay. So, great. So I took a 2.25 by 26 in the diagonal. My LAD, I have a 3.5 balloon because at that junction, it's actually quite by IVUS. So at that point, it was quite big there. So, and here, to address the question earlier for crushes, how far back do you bring your stent into the main vessel? Somewhat similar, I think, to the tap. You want it really as minimal as possible, but you don't want to miss it. You still want to be in the vessel itself. So here I did many different angles. I did an LAO, probably this is a little bit LAO-ish, really to make sure I'm just barely in the LAD itself. So my technique for a tap, I believe this is the correct technique, is I go up with my stent balloon to nominal pressure or however big I want to make it. You see I have a non-compliant balloon at the ready. I then pull back my stent balloon and do a kiss. Now, you could also, if you don't like the expansion of the tapped stent at the ostium, the side branch, at this juncture, you can also bring in a non-compliant balloon to make sure it's fully expanded. Failure modes for bifurcations so frequently are the ostium, the side branch. You want to make that ostial side branch really nicely expanded here. It looked great. This is an IVUS of the LAD itself. What I hate to see when I do taps or work on somebody else's tap is when there's a big nozzle of a stent hanging into the main vessel, right? So the challenge here is the angles are pretty shallow, so you're going to have a bit of a nozzle, like I like to say. But here, I thought this is pretty good. There's the tap coming in to the LED. So I thought that there's a LED proximal. So I thought that looked pretty good. Any thoughts about the tap? That's our so we've done. Let's see, we've done 2 provisional bifurcations. One has turned into a tap. Any thoughts on that tap before I move on? Tanvir, Raj, or Richard?
I think it looks good.
All right.
Do you do alternate high pressure inflations before you pull do the simultaneous kissing?
Yeah, and what I do is I go up to high pressure with my stent balloon or a new NC balloon if I bring that down. And then I just go to like 8 atmospheres on both because I don't want to, I want to make sure that side branch stent is fully expanded. So I may go to full pressure on both and then alternating 20 down, then 8 on both. I tend to go up first in the side branch just to make sure that it stays open or fully expanded. All right, so again, let's refresh our memories. We have this left main, which was the main reason why we were doing this procedure in the first place, but somehow this ended up being a diagonal mid-LED procedure. All right, so here we have it. So how do we address this?
You got to dilate that LED more. I mean,
yeah. Well, let's say we do that, it's fine. What's your technique going to be?
Well, the proximal circ looks like it needs to be treated, no?
Yep. So should I do another tap? Should I do a culotte? Should I do a T-stent? I can do an internal crush, I guess. All sorts of things I can do.
You know, it's not the largest vessel for space in terms of doing a culotte or reverse DK crush. I would try to think about a tap. I mean, just the left main is not the largest vessel here. You know, you could do a culotte, but
yeah.
I think
why not to do a culotte? Tanvir, you know, it's really narrow angle. You know, I think the circumflex, at least to my eye, looks like a minimum 3.5 millimeter vessel.
But
I would put in a
left main is not the
3.5/18
largest.
stent extending from circ into the left main, and then do another kissing inflection. But you know, many things.
You're a very smart guy. I know you're a smart guy. You can. So that was my plan too. So my thought was a culotte because the narrow angle. It's a big circumflex. The narrow angle, although tap can get you out of dodge very quickly, I just think here it's a pretty narrow angle. I don't mind taps in left main if it's really an orthogonal circumflex. So I thought this was, so I post-dilled the OSC-LED with non-compliant balloon. I then potted the left main because it's quite large. I rewired the circ. I opened up the struts with balloons. This was just a really nice stent viz I captured to show you what happens when you do a pot and a dilation of the struts into the side branch. And this is exactly what we want to see, isn't it? When you see that we've created this, you've wired in the right spot so that the main vessel struts have opened up to cover the proximal part of the ostium of the side branch, right? Right here, really nice. All right, so I put in a 3.5 DES for my culotte. I rewire kiss with 2 3.5 NC balloons. Terrific result. And in case you're wondering, by the way, here's the IVUS down below. I can't recall which, whether it's from the LED or the circumflex.
It looks good. And I can also see the bifurcation also looks good.
Right. And you can see how we nailed the ostium of the left main. It's nicely opposed. And here is a polygon of confluence right here. And those are the 2 stents, the osteos. That looks great. But you know what? He's complaining of chest pain again, and he has deep ST depressions. Like deep ST depressions, and he's not comfortable. Any thoughts? You can see the diagonals open, by the way. It's up here. What the heck is going on, right? Well, I went back to the beginning films. Here's our baseline, and here's now.
So first OM's lost. Yeah.
Yes. Again, distracted by the left main, right? If you go back, there is actually a lesion of the ostium of that ramus, isn't it? I'd actually pulled out all my wires here to show that on that picture, but that the wires were out, ready to go, and I look at STs are, I'm like, what the heck? All right, so we got to open up this ramus now. It was actually quite
like 2 layers now, so good luck. I mean,
yeah, well, there's well, I made sure not to double cover. One of the, we didn't even talk about this. A great point to have here is that when you're laying in stents is not to double cover bifurcations. So for example, if you're doing an OCT guided precision PCI and you got 65, 70 millimeters of vessel to treat, and you don't necessarily just split it into 2 because you want to make sure that your stent doesn't land at a side branch. So because if you put in two stents, you overlap them, That's
But
two
Matt,
linear thickness
didn't you
coverage.
have a stent in the LED to the left main initially, and then you took a stent from the circ back to the left main? So you had a double layer where the ramus was, no?
No, because the circ stent ended just past the ramus. So I closed the ramus when I put in the stent from the left main into the circumflex.
It's Richard, I don't think it's a true ramus, you know.
Yeah,
it
I guess
comes
that's
off
all right.
From
It's
just the
a high,
proximal side,
you're right.
right?
It's a high rising OM. I apologize for that. You are absolutely correct. I should be correct in my.
And so that's why there's only one layer. Nah?
Okay,
Yeah.
that makes sense.
Yeah.
Okay.
Oh my God, you're right. I'm sorry. Talking too quickly. All right, so I wire it. Actually, use a pilot 50 to wire this. Put in a 2.0 balloon. This is what I got. Okay, so first of all, would you have put a wire down the circumflex and done a kiss, or did what I do? I just quick and dirty put a 2.0 balloon, went to 8 or 10 atmospheres at the os.
My vote is that this is enough.
Yeah, you've done enough for this patient. Well, is this chest pain better though now?
Yes.
Okay.
And actually, I think this is it. So that was my last. In fact, I didn't even take another picture because we were on the table for so long. He went home. I kept him overnight. He went home the next morning without an issue.
The key had no pain or ST, so
Nope.
do no harm.
I think it's good. You know, there's just too many, vessels.
Enough.
So this is when provisional stenting becomes, problematic. But I wouldn't have actually changed my approach other than maybe being a little more aware of that diagonal initially. But even so, even looking back, it did not seem so terrible of something that would need to be covered.
Great cases. We're coming up to time, but thank you so much for sharing all this. I think this is great learning experience today. So we write at 7. And thank you everybody for joining us today, and great cases to share. And thank you, Dr. Hassoon, all the way from the UK, and joining us. Thank you so much.